Okay, I guess the time is is getting on, so I better start. I'm J.Marini from University of Minnesota in Minneapolis and St. Paul in the United States, and the tutorial is intended to be talking about the ventilatory management of ARDS. And all of us take care of ARDS, and I don't think I need a case to work my way through the concepts, but to transmit to you what I think are the important concepts of how to take care of a patient with ARDS from the ventilatory standpoint. I don't have any relevant relationships with any entity that produces, markets, resells, or distributes healthcare goods and services. I do have a few books out there. Well, ARDS, we talked about this very early in the meeting. It's depressing to me, actually, over 40 years to know that my interest is in this thing we call ARDS. But ARDS itself is, in fact, not a very well-defined entity. And I say in the beginning was the word was ARDS, and it was Dr. Tom Petty, among others, who brought it to our attention. And the umbrella of ARDS hides pathophysiological differences, which means that the ventilatory management has to change as well. For many of our ARDS patients and recently CARDS patients, the pathology and PEEP response evolve radically over time. This is another thing that is a little bit eye-opening to those of us who've been around a while. We talk about optimal PEEP and we talk about various aspects of what we should target for driving pressure, etc., without understanding that underneath it all, the disease is progressing from an edematous phase to an organizational phase to a fibrotic phase in those patients who don't recover. And driving pressure will have a much different implication for the latter than from the former. And maybe nothing we do with our ventilatory management makes a great deal of difference when the patient is progressively getting worse. We like to think that ventilating in a certain way will help, but in all honesty, I don't think we even know that. I'll talk more about that as we go on. The perpetual question has been, how do you set PEEP? Do you set it with gas exchange, looking at oxygenation, and rarely, but preferably with carbon dioxide, exchange kinetics, hemodynamics, mechanics, and lung stress and strain. Here in Europe, people are talking about lung stress and strain as being the quintessential criterion of what a good ventilatory strategy is. But in fact, the other features, the hemodynamics and gas exchange features, are equally important or even more important than the lung stress and strain confinement that we concentrate our attention on. This may sound funny coming from me, who studied ventilator-induced lung injury in the laboratory, but at the bedside in the current day, I'm not sure that we are influencing the course of the patient very much. When we change the driving pressure from 13 to 16, or we adjust our PEEP from 8 to 10, it may make very little difference. And we'll talk more about the reasons for that later. Years ago, Crotty and Luciano, and I was part of the study, showed that if we look at the inflation percentage, going from an airway pressure of 0 to an airway pressure of 50, we have what the expected curvilinear profile. But also, the recruitment percentage goes up as well, in more or less the same way. It's basically saying that even if you don't have very much recruitment going on, the recruitment that you do have available will be maximized at high pressure. That's basically the message of the paper. This is a a study that I think everyone should reread now. 1975, Peter Suter in New England Journal of Medicine demonstrated for us that if we look, If we look at the tidal compliance, and we look at the cardiac index, and we look at the dead space, we can find that the best compliance and the least driving pressure is associated with the maintained cardiac output and the least dead space, suggesting that that's what we ought to be targeting at the bedside. And really, now more than 40 years later, I'm not sure there's a better study out there to guide us. At that time, they were not concerned about VILI. They were concerned about oxygen delivery, the amount of oxygen in each milliliter of blood and how many milliliters of blood were circulating per minute. The quest of the Holy Grail for the best PEEP has progressed from 1970 to the current time through various stages. And in the beginning, oxygenation, mechanics, and hemodynamics were all considered. And over time, basically, what happened is that we have concentrated almost exclusively on oxygenation in terms of the severity of disease, for example. When we talk about mild, moderate, and severe ARDS, we define it on the basis of oxygenation. This makes some sense, but in fact, it's not what it's not in fact a good way to look at it, because oxygenation can be affected by many different things beside the recruitability of the lung and the optimal characteristics of the ventilatory process. This is from a paper that Luciano and I have written and will appear shortly in the literature. So the evolving concepts in lung protection, if we want to focus on lung protection for the moment, are we've gone from low tidal volumes to low plateau pressures to high PEEP open lung approach. Now everyone's concentrating on low driving pressure. 5 years ago, low ventilating power, energy per minute. And in fact, I think we're still fixated on low driving pressure as what we ought to be thinking about at the bedside. I want to tell you something. Driving pressure is very important. It tells you what a given tidal volume takes in terms of the pressure that's being generated because of the size of the baby lung. If the size of the baby lung is small, the driving pressure is high. It doesn't mean that if we adjust the driving pressure, we can change the ultimate pathology of the lung. And power is not the answer either. The energy per minute is not the answer at all. As Paul Wishmeyer may have mentioned before, these exercising patients, which is a fundamental part of their therapies, are ventilating with powers that are enormous, but no threshold for strain and damage has occurred, and so they do fine, as any normal individual would. So power can't be the whole answer. There must be some other component that we're not considering. The driving pressure rationale is, as I think you all know, driving pressure is plateau pressure minus PEEP. It's ratio of tidal volume to compliance. And it is said the tidal volume normalized to the capacity of the baby lung. And it's a very attractive and viable concept. This is a very nice paper suggesting that the combination of driving pressure and frequency is at least as good as using ventilating power as a risk factor. So driving pressure's value as a VILI risk factor may improve after considering its repetition rate. This may be true, but again, I bring back to the same concept. If you have driving pressure, which reflects the status of the lung and the frequency with which you're overventilating that lung, that small baby lung, it's not surprising that the combination of driving pressure and frequency would be associated with a mortality difference. That's not telling us much about the mechanics of what's going on. Maybe all you need is driving pressure and frequency. This is what we just heard in our previous session. And that if you look at a statistical analysis and a population-based analysis and look at who dies and who does not, maybe driving pressure and frequency combination does as well as anything else you can use. But if you ask the fundamental question, can any pressure acting alone really cause ventilator-induced lung injury? And I kept on thinking in the last session I was in, everyone is talking about correlations and forgetting it's not causation. For the reasons I've just mentioned, respiratory rate's important maybe because the sicker the lung you have, the smaller the lung you have, the more diseased lung you have, and it's not necessarily causing injury to the lung, the driving pressure frequency combination. As Bertrand Russell said, the whole problem with the world is that fools and fanatics are always so certain of themselves and wiser people so full of doubts. And I'm one of those who's full of doubt. Unlike a balloon, it's difficult to inflate and damage a stiff lung unit. And remember, when we're talking about the diseased lung, we have individual lung units that we must be considering, not the whole package. We measure the driving pressure at the airway opening, but what we're really concerned about is the individual lung unit. If you try to inflate a stiff lung unit, and how can it be stiff? It can be stiff because it's flexible but surrounded by other tissue which is holding it together, buttressing it, so to speak. Energy input is needed to damage tissue, and energy can't be created or destroyed, only transformed. I don't want to bore you with all these details of, what I don't use at the bedside, and I don't think you do either. We don't measure the energy. We don't measure the power even in most cases. But if we were to look at what causes the energy input, which is fundamental for damage, we have to think about several components. The first component is the flow component, which I talked about in the previous session. The second is the driving pressure component, and the third is the PEEP component. And all of them are important. If, for example, we use the same driving pressure and take it from a low airway pressure to a higher airway pressure and cross a threshold where damage begins to emerge at this point, the same driving pressure may damage very severely some lung units. Maybe fewer lung units will be available because they've been recruited, but the damage is more severe. PEEP adds to the total strain. It adds to the risk of ventilator-induced lung injury. Point clinically is that I don't use any more PEEP than I need to. It's very important not to do that. And I think the supine position for some patients is perfectly fine if the threshold pressures are not high. If your plateau pressure is not high, your driving pressure is not high, supine position is fine. Once the pressures become high enough to be concerning, then turning to the prone position is beneficial. There's likely to be a damaging stress and strain energy threshold per cycle. This is a constant flow simulation here. You've got PEEP, you've got the driving pressure increasing to its final plateau pressure value, and you've got the flow resistive energy block here. Once you cross a threshold, then the extra energy that you put in becomes important. And which of these blocks of energy is the most important, I'm not really sure. But they all have energy associated with them, and they all have power associated with them when you multiply by frequency, or if you change the flow profile, like I mentioned in my last talk. Neither driving pressure nor power alone is enough if we're trying to protect the lung. And I must say again, I'm not entirely sure that lung protective ventilation is as important as we have said it has been. You know, we like to think that things that we do at the ventilator bedside help a lot. I think when you stay within certain constraints, you're probably doing as well as you possibly can. You know that lung stress is proportional to transalveolar pressure. You can have the same lung size associated with very different plateau pressures depending on what is the pressure that surrounds the alveolus that you're talking about. So transalveolar pressure is what we're interested in, but no one ever measures the esophageal balloon pressure, and I don't in my practice either. If I ask myself to my colleagues, is the plateau pressure safe? And they say, oh no, it's over 30. Over 30? Okay, what does that mean? Is the patient actively breathing? Is the patient passive? Is the patient upright? Is the patient horizontal? All of those things influence the transpulmonary pressure. So don't get fixated on specific numbers and numerical guidelines. That's a clinical message I want to transmit to you. Increasing abdominal pressure reduces lung volume and respiratory compliance. Whether people say it does or doesn't, I guarantee you that the lung volume will shrink if you increase the intra-abdominal pressure. We've done this in the laboratory, and at the bedside this happens, of course, and I think any clinician knows this. To undo the upward pressure of the abdominal forces and of the weight of the thorax, you have to use a much higher PEEP in this situation than in this situation to get to the same expansion of the lung units. Be wary of numerical guidelines and tables based on airway pressure. In America, I'm sad to say, we start, in many cases, in many hospitals, with the PEEP tables. The PEEP tables that the ARDS developed and published, and people use them and say, okay, I can use this FiO2 and I can use this PEEP because I have this P to F ratio. Those numerical guidelines just don't cut it. It's not what we should be thinking about. Mechanical heterogeneity of ARDS causes stress focusing, and various sectors of the lung will be damaged more or less, strained more or less, depending on what the external pressures are and how close you are to a lung unit that will not expand as you're expanding the others. This is an image I like to show of a patient that when I was practicing medicine, this is not my patient, fortunately, a young man with ARDS who died, came to autopsy, and what do you see? What you see is that in some zones, you have complete consolidation and fibrosis. In other zones, you have emphysematous changes that were not there before the inflammatory process and the pressures that you were applying occurred. What's the message here? The message is that the central airway driving pressure alone does not account for the diverse regional damages. You must try to homogenize and reduce the ventilatory demand, the oxygenation demand of the patient, for multiple reasons: ventilation and the blood flow through the lung. You need to make things more uniform, the transpulmonary pressures less, and that's the way to do it. The damage from a given driving pressure depends on lung unit compliance and the lung unit tidal excursion. If we have a driving pressure of 20 centimeters of water, we go from 5 to 25, people 5 to 25, and here we have a small volume change, we have a small energy input, because it's the pressure change times volume that's the energy. There's not much volume change going on with this high pressure change. Here, just the opposite happens. There's a large volume change, a high energy input, more strain, and the lung unit is overstretched. The point is here, we're measuring at the airway opening. What we're interested in is at the micro level. And so as important as anything else, we need to make the spectrum of lung units as uniform as we possibly can. Proning redistributes lung stress in a way that we all know about. In this paper from our institution many years ago, we showed that these animals that were ventilated supine had tremendous damage in the most dependent zones. These were not the most stretched zones. These were the force amplified zones and the most better perfused zones. The most stretched zones of these animals were actually pretty normal at autopsy, even though the animal died basically of lung failure. In the prone position, there was much less damage apparent, and even at the same very high inflation pressures. So proning evens and reduces the stress and VILI. Okay, I won't go through this because we know what we're talking about here. Prone positioning is often effective in early and mild cases of hypoxemia. We've learned that in CARDS, COVID-19 ARDS. Proning acts by diverse mechanisms, and it acts slightly differently in CARDS than in routine ARDS because of the perfusion shifts that don't usually occur, do occur in CARDS. So prone positioning is often effective in early and mild cases of hypoxemia, but not so much in the later phases when the lung is more fibrotic, less recruitment is available. And the stretching forces may be less imperative to control in the latter phase. I talked about this in the last section. The flow profile distributes the intracycle power and energy differently in ARDS. If we look at pressure preset ventilation, which is pressure controlled ventilation, and compare it with constant flow, decelerating flow, or sinusoidal flow, we get quite different patterns of power distribution over time. And if we use different compartments with different mechanical properties, we also get very interesting distributions of stresses and strains that I don't want to get into. The principle of power concentration is very important, the shrinking baby lung. As we go from an airway pressure of 30 centimeters of water and a global power of 4, and then go to an airway pressure of 30 and a global power of 4 joules per minute, the specific power in this lung is much, much higher than in this lung. So what's the point here? The smaller your baby lung, the more likely it is that it's going to be susceptible to power concentration. And the pressures help you, but they don't tell you very much. The airway pressures are identical in both of those circumstances, all of those circumstances. We wrote about this in 2020, looking at the concept of the shrinking baby lung. As the lung gets more and more damaged, the airspace becomes smaller and smaller. The same power being put into the same lung, the same pressures being put into the same lung, progressively damage the area that's left. I mentioned this before, that the flexibility of the lung unit is influenced also by what happens in the area that surrounds it. As you go from a lung unit or a lung with multiple lung units to one with fewer and fewer, at end expiration, the lung units look the same, the ones that are left. But the end inspiratory lung unit is overstretched in the latter condition. Okay. Is CARDS really different? I don't want to spend much time on this because my time is essentially up. But for CARDS, time changes almost everything, meaning that we must personalize management in this and all forms of ARDS. If we look from the early phase to the late phase of CARDS, we see very different properties. We see the lung compliance going from a good value to a low value, PCO2 rising over time, and yet oxygenation doesn't change much because there's a disconnect between the oxygenation and the mechanics in this situation. There's a lot of people who think that it's just the same as everyday ARDS. It is not the same as everyday ARDS. It changes dramatically from the beginning to the end. And the last thing I'll mention is that quite recently we've been showing that many of these patients, especially in the late phase or the severe phase, will have a plateau pressure and a driving pressure that fall when you change the chest wall compliance, increase the elastance of the chest wall. You'll find the plateau pressure falling, the compliance actually improving, and this is the compliance of the total respiratory system. It's a diagnostic procedure that can tell you that the end inflation properties of your lung units are being overdistended. This, I think, was the first paper that said that. And basically what we showed is that if you had a plateau pressure that was quite high and you put a weight on the sternum or you pushed on the belly and found that the plateau pressure fell, then the end inspiratory hyperinflation was very considerable throughout the lung. And again, Luciano and I wrote about this, how we could improve lung compliance by external compression of the chest wall. And it's too complicated to introduce it in this tutorial. But the point is the personalization and the diagnostic physiology is very, very important. You can also do it in the prone position. You can put binders on. To improve the mechanics of the ultra-small baby lung, reducing PEEP, reduce tidal volume if it's possible to do so with adequate CO2 exchange, body positioning, less upright positioning, and chest wall compression, maybe, as techniques to use to improve the compliance of the underlying baby lung. So there are multiple components of VILI risk. Cumulative injurious strain is probably the most important of all of these. And you have to be very aware that what you're adjusting with your ventilator may not be as important as what's going on underneath. And you want to change the modifiable determinants of VILI and lung protection, translung pressures, plateau pressure, driving pressure, and PEEP, conditional cofactors, position, vascular pressures and flows. The higher they are, the worse. Body temperature, the higher it is, the more likely it is you're going to express inflammation. Airway propagation of injurious biofluids, perhaps. Last point, you want to reduce the oxygen demands of the patient. The oxygen demands of the patient, not to provide less oxygen, but try to make the oxygen demands of the patient be less. That can help you from the ventilation side and from the perfusion side. Minute ventilation and inspiratory flow are are features that we're still exploring, but we think are really quite important. You got to remember at the bedside that a little personalized physiology goes a long way, and a lot of our clinical trials, sadly, are leading us in the wrong direction. We need to be physiologists again. And I think that's what attracts young students to the bedside, to critical care medicine, and then we teach them to label things and look up things, and we shouldn't be doing that. We need to reassess our patients frequently because the underlying pathology is changing, and those are the kinds of messages that I think belong in a tutorial. Those are the principles. And that's still a consensus of two after many years working together with Luciano. So thank you very much. There are lots of pieces to the lung protective strategy. Most importantly, think at the bedside, test what you think you know, and readjust if necessary. Thank you. We're kind of long on time, but if anybody has a question, I'll be glad to answer it. Yes, sir?
Can you please tell us when should we ventilate this? You said the 3 stages, HPU stage, the ICU stage, and then the 1 stage before, like COVID ARDS. Yes. So will you profess that before the consolidation occurs, you should intubate them? Or should we just go by the numbers?
Well, you know, I'm not the world's expert on CARDS to tell you the truth, but I would say that you do not intubate anybody prematurely. But if somebody continues to labor, continues to have problems with gas exchange oxygenation, is developing signs of fatigue, then that's the time to intubate and take control and then reduce the flows and volumes that you need to use in a controlled setting. That early intubation question has been percolating for the last 2 years. Should we intubate them earlier or should we wait until we're forced to intubate? I'd say intubate them earlier if the patient is showing any sign of deterioration. And that sign of deterioration can be fatigue, it can be an oxygenation change, a CO2 elevation. Those are the kinds of things that I look to. Okay, thank you.
Thank you for one last question, please. So you said in multiple occasions that the changes in our settings in the ventilator don't affect the outcome that much. This morning, we just heard that the driving pressure is strictly and directly correlated in patient mortality. How do you not agree with that? Thank you.
That's a very nice question, and I agree entirely with the concept that you should not use any higher pressures than necessary in a given individual. However, to correlate driving pressure and frequency together and say that manipulating either one of those is going to improve your outcome, I think that's the wrong view. What's happening is the driving pressure, most people are controlling the tidal volume, and the driving pressure is an indicator of compliance. Compliance is an indicator of how sick the lung is. So naturally, if the driving pressure is going up and the patient is getting sicker, then that could be the reason why there's a strong correlation between driving pressure and mortality. It's not to say that if we control driving pressure or we control plateau pressure or any of these things, and what pressure are we talking about, please? I mean, you've got to let me know. As I mentioned, numerical values, without knowing the transpulmonary values, those those are just numbers. So I love the work that Marcelo is doing. For example, I like it very, very much. I love him personally as a friend. But there's two things we've got to remember. We like to believe that what we manipulate at the bedside is critically important. And if we do extreme things, that's undoubtedly true. And if we're looking at the individual patient, we do want to reduce pressures. We do, that will be the safest thing to do if we achieve our other objectives of ventilation. But on the other hand, I don't know how much the lung protective strategy is really contributing to the mortality that we're observing associated with driving pressure, frequency, or power for that matter. And as I say, power, if Paul Wishmeyer were out here on his treadmill, his power levels would be not 8 joules or 16 joules, they would be 65 joules, and he'd be perfectly fine. It can't be just power. It's got to have something to do with driving pressure, and driving pressure has something to do with compliance and severity of disease. So I know that's a kind of a confused answer, but that's the best I can do for that. I think we should try in our patients to use lower pressures, but just how important it is and just how exactly we can be guided by numbers, I am very, very much in doubt.